So for our next presentation, you're still stuck with me. We're gonna go into a talk that I've started calling Technique Matters. And so we'll get underway. Fortunately, you've already seen this picture, but there's not that many of them of me out there. So Technique Matters. I know with this room, this is not going to be a very controversial statement, but I feel like the reason all of you are here is because we believe that technique matters. This is a phrase that I've heard Dr. Verghese say over the years, which is to say that the way we examine patients, our technique really matters. If we do our physical exam technique incorrectly, we're not going to find the signs. Our technique really matters. In fact, it's usually what I say when students, we need to get to the bedside to examine this patient. And if they're doing it wrong, I'll remind them that, hey, your technique matters. But here in this picture is another example of technique. And what I'm going to be talking about with you all for about the next 20 minutes is we're going to be talking about our technique in going to the bedside. How is it that we get to the bedside, how we conduct ourselves at the bedside, that technique matters as well. Now, most of us, when we think of the bedside, and this is certainly true for myself, I think of this, a hospital bed. I'm a hospitalist. That seems pretty natural. And I think most of the time when I talk to people about bedside medicine, that's what they're thinking about. But as our group has evolved, we've come to recognize that this is just as important. The exam table in the clinic is going to be just as important for bedside medicine and for teaching clinical skills as the hospital bed. I think it's just a bit of tradition that we've often focused on the hospital. But there's a whole slew of techniques that you're going to need in the clinic, and that really only come out in the clinic, and that we have to be teaching this both in the hospital and in the clinic if we want our learners to get all of the skills that we expect them to have. Now, the other thing that is going to be important is to think about the context. So this is a slide that you can see. They're clearly in, again, a hospital setting, and they're probably on rounds. And in fact, if I go up and tell people, oh yeah, I'm really into bedside medicine, I'm really into teaching at the bedside, most of them will assume that we're talking about going around on rounds, seeing our patients, seeing the patients we're taking care of, and maybe doing what I just talked about, which is taking 5 minutes to teach them something at the bedside. We point out an exam finding, okay? We go over how to ultrasound the IVC because we're trying to understand what is this patient's volume status. But what I want to talk about over the next 20 minutes is setting up actual teaching rounds. And so I've been lucky enough that since I've been at Stanford, there's been regular teaching rounds where we take students to the bedside, not because we're taking care of these patients, but purely just to learn. And I know many of the institutions out there are doing the same thing. And they're really valuable, but it's kind of a different context. You don't know the patient. Okay? The students, maybe one of them knows the patient, but frequently they don't know them at all. So it's sort of a different context, and how you teach might be a little bit different. We're lucky enough here at Stanford, we do this as part of our medicine clerkship, but there's also situations during our practice of medicine course in the first 2 years where we get to take students to the bedside. So we have lots of opportunities to do this, and I always want to make sure that we do it as best as we can. So I'm going to take you all a little bit on my journey to doing this. And so when I was a chief resident, I had lots of time to learn how to teach at the whiteboard. I was really good at teaching at the whiteboard. I was at that whiteboard every day. It was not nerve-wracking for me to teach at the whiteboard anymore. I knew what I was going to say. I could control the session. I could control who I asked questions from. I could stop asking questions if I didn't like what I was hearing. I controlled the topic. I controlled when it started and when it ended. The whiteboard had no surprises. But I'll be honest with you, when I first got asked to start doing bedside rounds, I was really nervous. Because the bedside was full of surprises, okay? When I was going to the bedside, I didn't know what I was going to see. I didn't know what was wrong with the patient. I didn't know if I was going to be able to find any physical findings to talk about. Wasn't sure I'd be able to answer the questions the students asked. So to me, the bedside was actually really pretty intimidating. And I'm not sure I was the only one who felt that way, but certainly as a junior faculty member, I was pretty nervous to start doing bedside rounds. And each time we'd start, I was like, I'm sure the students are going to figure out that I don't know what I'm talking about this time. Survived the last one, but this is going to be the one that gets me. I was lucky enough, though, that when I started this journey, that all during my chief year, we would go to the bedside with Dr. Verghese. So it was myself and my other co-chief residents. Every Friday afternoon, we'd go to the bedside. It served a couple of purposes. So one really important purpose was if we were taking care of a patient, we didn't know what was wrong with them. We'd say, hey, Dr. Verghese, maybe you'd come take a look at this patient and share your wisdom with us, which was actually really, really nice. It was a really collegial and fun way to learn from someone who had a lot more experience than I did. But frequently, especially towards the end of the year, we were feeling a little bit more confident. We could go to the bedside and really just learn about how to teach at the bedside. And it was a really wonderful thing to do, and I got to learn about Dr. Verghese's repertoire of physical findings that he likes to teach about. I got to see how he was able to engage the patient, make sure they were comfortable, how he could practice physical exam skills in a way that was respectful of the patient. This was clearly super important, but probably the most important thing I learned going to the bedside with Dr. Verghese was how willing he was to say, I don't know. We heard that a lot as chief residents, not because Abraham does not have a lot of knowledge, but he was clearly comfortable with saying, oh, I don't know that. There was no problem with that, and to me, that made me feel a lot more confident. Here's a guy who's been doing this a lot longer than me, who's had way more training than me, way more experience, and there's clearly a lot of stuff out there he didn't know. So I needed to feel comfortable as well when I took students to the bedside, saying, I don't know. But nevertheless, when it turned out to be my turn to go to the bedside, I felt a lot more like this guy. For those who don't know, this is Dr. Nick from The Simpsons. He's not a very good doctor. But I felt a lot more like Dr. Nick going to the bedside than I did like Dr. Verghese. And the reason was, when I first started going to the bedside, I had this wonderful model to emulate. The problem was, I was just trying to be the model. I started pulling out Dr. Verghese's anecdotes and his stories and tried to kind of do his repertoire. And what I'll say is that just doesn't work. You're just pretending. You're just kind of acting. And so what it took was, it took practice. It took time. But slowly, I kind of built up my own 5-minute bedside moments. I built up my own things that I was comfortable teaching students about, so I could take them to the bedside and be excited about it. And I'll be honest with you, it took years before I felt really confident and comfortable saying, what are we going to see today? Let's go to the bedside and see it. That sounds great, without being nervous that I'd be missing something. Now, along the way, I learned a few things that maybe didn't work so well. See, Dr. Verghese already alluded to one of them, which is that size matters. If you go to the bedside with this many students, it's not going to work. Now, at Stanford, our clinic rooms aren't particularly big, and I can promise you our hospital rooms, until we build the new hospital, are actually quite tight. We do shared rooms here. There's not a lot of room at the bedside. I would say max is going to be about 5 or 6 students, and 6 is even pushing it. Why is that? When I go to the bedside, I want to make sure that all of my students get a chance to practice. Certainly if there's something interesting, certainly if there's some technique involved in what I'm teaching, they all need to be able to practice. And at the very least, they need to be able to see. And at least in our hospital, with the size of the rooms the way they are, if you go to the bedside with more than 6 people, they can't even see, let alone practice. And so you have to be really careful about size. It makes it really hard to scale up this. When putting this symposium together, we thought a lot about size. How many people can really learn physical exam skills in a room like this? Not easy. Another thing that was really important is what I call respect for learner. One of the things I started doing, which I was really excited about, is I started having my students and my residents present at the bedside. And I know from some of your responses to our survey that some of the institutions out there are doing that. Some aren't. It seems to be, in some ways, to be a little bit of a lost art. But I told our students, I know you guys aren't used to doing this, but I want you to present right at the patient's bedside. Some people still refer to bedside presentations as the ones that go on in the hallway. It's close to the bedside. It's just not at the bedside. And I'll be honest with you, a lot of the students were pretty reticent. And so I debriefed with a lot of them. I said, what did you guys not like about that? What didn't work for you? And what I heard over and over again was that these students were trying really, really hard to build up a good rapport with their patient. They were trying to demonstrate to their patient that they're trustworthy, that they're someone that they are worth looking to care for them. And that when we presented at the bedside and I told them that I don't really know about that plan, or what do you know about this, and they didn't have anything, and they felt it really damaged the relationship that they were trying to build up with their patient. So I have not abandoned bedside presentations, but I have had to adjust a little bit about how I conduct myself at the bedside when they're doing that. So I try not to make any comments that could in any way denigrate that relationship. So rather than saying, and I've been guilty of saying all these things, I know all of you learned this in first year of medical school. Who wants to point out the JVP, right? That is not going to look very good when they can't find it, right? At least the patient's going to be saying, why can't these kids do it? The guy just said he learned it first year of medical school, right? And so, instead I might say something along the lines of, I'm not sure any of you have learned this before, or let me teach you a new technique to find that, to make it really obvious that they're not supposed to know this already. I certainly try to keep any bedside pimping to a minimum. It doesn't mean we can't ask questions, but I try to sort of diffuse any question by letting them know that it's okay that they don't know the answer. It's certainly okay for the patient. And I think if I do that, it goes much, much better. They're still not perfect because many of them still get nervous. Another thing I'd like to point out is respect for patient. So I think if you'd asked me 10 years ago, there's no way I would have believed you that I would be the one standing up here saying how great it is to go to the bedside. In fact, when I was a student, I'll be honest with you, despite having a lot of great teachers, I often felt pretty uncomfortable at the bedside myself. I was often pretty sensitive to the patient's needs, and if I saw anything that even looked at anything like disrespect, it really just made me uncomfortable, made me cringe, and I wanted to get out of there. I still see this with our students now, especially our early students. During the practice of medicine course, they're supposed to go and take a history from the patient and then do a physical. And many of them are so respectful of the patient, which is great, but they end up not doing the physical. It's like, oh, I didn't want to sit them up. They might be uncomfortable. Or I didn't want to take their blood pressure. I really didn't want to bother them, right? And again, I think it's great that they have that much respect for the patient. But it's almost to the point where they're afraid to do the physical exam. So you almost have to understand that that is the mindset of your student, because I suspect all of you in this room wouldn't feel uncomfortable taking the blood pressure of a patient because you might inconvenience them. You know that these patients are getting their blood pressures taken almost continuously, right? And so doing it one more time is probably not going to be a huge inconvenience. But for the student mindset, it's a little bit different. I'll share a quick story just to kind of illustrate this a little bit. And so this was probably the most egregious thing I saw, but I was in my last rotation in medical school. I was having a great time. It was dermatology clinic. I was there. I knew I was going to be an internist, but I wanted to learn as much as I could about the skin before I went into residency, and I was excited to be there. And I was really lucky that everyone in that clinic thought the same thing. They're like, we know you're not going to be a dermatologist, but we're excited to show you as much skin pathology as possible. So I'm having a great time. Pretty soon into the week, I hear what is the unmistakable sound of a turkey call. And this is not like a faux turkey call. This is like a legitimate professional. If there were turkeys in the building, they would have come to this room, turkey call. And I kind of look up at my resident like, what is going on? But everyone else knew exactly what was going on. And that was the signal to pile into the hallway and get to that room. And we're not talking just medical students. We're talking about every resident and attending in the clinic. That was their signal to get to the far end of the clinic and get into that patient room to see what was going on. It wasn't like a code, but you can kind of think of it as a code physical exam finding. And sure enough, you'd get down there, and there would be some amazing finding that you'd never seen before. And it was awesome. Turns out, though, that didn't always work well. So I still remember, it was kind of towards the end of my first week. I hear the turkey call. I'm excited about it now, right? I know there's going to be something good. And so myself and there was one other student on the rotation with me. We're kind of the first ones down the hallway, tailed by a bunch of other people. And we get to the room, and there's a young woman there who's just bright red and crying. Turns out the redness was not the physical finding. The redness was a sign that she was extraordinarily embarrassed that there was a man in the hallway making a loud turkey call. And that even worse was that was followed by 20 people piling into the room. And again, this is not a big room. There's now 20 people in this tiny room, and now she's just red and crying. Right? It clearly did not show the respect for the patient that she needed. Right? And that was clearly a problem. Again, I don't think the teacher had any malicious intent. In fact, this teacher was about the most passionate person I'd ever seen in terms of teaching physical exam findings. He wanted to make sure that everyone in that clinic upped their game, that got better. Okay? The problem was it just didn't work for this patient. The other problem was that for all of us who were now sitting in that room cringing, all of us did not want to go back to the bedside. Most of us were like, oh, God, the turkey call. What's going to be there now? And it was still going to be an interesting finding, but it might be someone who was really, really offended. And it made the entire atmosphere now really, really uncomfortable. And so I'll say that as you're going on this journey, if you're thinking about starting education rounds at your institution, or if you're already doing them, just keep that in mind, that the learners are always going to be more sensitive, probably than you are, to the patient's comfort. And if you don't focus on that, you're going to have problems. There we go. So whenever we start out bedside rounds, and I actually brought one of my students here who's going to be experiencing that for the first time tomorrow, I always say the same thing, which is, who's got a good patient for me? And the most common thing I get is people kind of looking down. Sometimes someone's like, I got one. And they're really excited. But oftentimes people are like, oh, no, you don't have one. And it's because universally students think the same thing. They have to have like the most amazing physical exam finding. There's got to be like a cardiac friction rub or Kussmaul sign. You know, they're like, it's got to be awesome. And what I always tell them is that they don't need to have amazing signs for us to learn. In fact, I'm perfectly willing to go to the bedside of a patient who doesn't have any known physical exam findings. Chances are we might find something cool to talk about, even if the signs were unknown. Okay? But even then, even if all signs are negative, there's still going to be some profound learning there. So what I tell them is they still have two rules, though. Rule number one is the patient has to be willing. And that means that if you've got a poor patient who's completely demented and A&O times 0, that's not technically willing. Right? They need to know that we're coming there to do purely educational rounds. We're not their doctors. We're not taking care of them. Okay? And so they really need to be able to say, hey, I'm okay with you all coming in and teaching. All right? And so that means that someone has to really be able to consent to that. The other piece is that I think that the patient really should be able to understand what I'm saying. And since I usually conduct rounds in English, they really need to be able to speak English. Again, if you perhaps had a translator that was walking with you and could translate everything you're saying, that might be okay. But in the absence of that, they really need to understand what you're saying. It's one, so you can consent them, and two, so they're not like, what is this guy droning on about? Is he making fun of me? Is he saying something really bad about my condition? Right? There's no quicker way to confuse your patient than to go in there and start speaking a language they don't understand and then just walk out after having a bunch of people nodding, especially when there's a crowd. Right? They're going to think something's terribly wrong. Right? So those are kind of my two rules. I say, hey guys, if you have any patient that's willing and can understand what I'm saying, we're good to go. We're going to learn something. Because what I'm going to do is I'm going to ask them what their chief complaint was. So what is it that brought them into the hospital? And then we're going to talk about, well, what signs should we look for based on that chief complaint? And then we're going to actually look for those signs together and make sure that we can see them. So there's a few things that I talk about, what I think of as my recipes for successful teaching rounds. So when we start out, I set the agenda. I pre-brief with the learners. I say, what is it that people want to work on during this session? Is there any physical finding that's been really tough for you guys? Are you struggling with reflexes? How is your neuro exam? Are you able to do cardiac auscultation okay? You know, we really talk about is there something that's been vexing you for the past week or two? And make sure that they don't have any major issues. Sometimes they have something they want to work on, sometimes not. And make sure everyone knows what the goals of the sessions are, right? So we're going to the bedside to learn about physical exam findings. We're going to the bedside to learn when you have a certain chief complaint, what type of exam should you do? Then I make sure that the patient knows why we're there, right? So if we're going in there, they need to know that this is purely educational. Now I let them know that if we find something strange, that we will go back to their team and tell them about it. If they have a message for the doctors who are caring for them, we'll go back and talk with those physicians. But we're not the ones who are directly involved in their care. And I find that even if I make that really explicit, there's still often some questions about it. So sometimes I need to re-clarify that. There seems to be an issue sometimes that patients just think we kind of all have one giant brain that we share. And so it's very important that you're explicit that you're not part of the care team. Another thing that I find really, really important is the role modeling that we do. And we kind of already talked about this a little bit, the way we conduct ourselves. But I really do think that when we go to the bedside, the students really do pay attention to that. And the reason I know that is they tell me about it. Okay? And so some things that all of us have learned at one time or another, like getting eye level with patients, making sure we ask them how they would like to be addressed. You know, again, really basic things. Asking permission before we do any part of the physical exam. Really, really basic stuff is key, because this is when the students are paying extra close attention. And so I really, really try to stress how we do that. In terms of asking permission, I'll always ask permission for myself if I'm going to demonstrate a physical exam maneuver, but then I always make sure from the patient that I'm going to say, oh, do you mind if the students can all listen to your lungs as well? Is that going to be okay with you, right? Before we actually get into that. And make sure they're all okay with that. Sounds, again, pretty basic, but if you don't do it, there can certainly be some issues. On that same note, you really have to make sure your learners practice. Over and over again, I see that if the learners are just watching me, and it's never become more clear as with ultrasound, if they're watching me do it, they are not learning. They need to be doing it themselves. If your goal is to improve technique, they might see a nice demonstration, but until they go to practice, they're not going to understand where the issues are. The other thing, too, is to know that when you're going to teach something, especially an exam maneuver that has some technique involved, make sure you understand how the students often mess it up. What are the challenges of that technique? A great one that I love is percussion. Right? So we always teach percussion to our first-year medical students when they're learning how to do their exam. And if they just watch me do percussion, they invariably start percussing like they have a hammer that's trying to drive a nail. Okay? So it really takes me to understand that you really need to get them to have a loose wrist so they get a little bit of snap in their percussion. So that's what I'm looking for. I know to look for it because I know what they're going to do wrong. They all kind of do the same thing by having a really, really stiff wrist. And so by kind of predicting with your physical exam maneuver how it might go wrong, you're going to be much more efficient in the way that you teach. I always finish each session by making sure that the patient has a chance to address the students. And so what I'll usually say, especially if they're not too verbose, but I'll usually ask is if someone who's pretty chronically ill, and in our inpatient units, we get a lot of people who are very chronically ill and are often in and out of the hospital all the time. And so I'll just make sure that I'll say, do you mind giving some advice to our students? Again, I think it shows a lot of respect for the patient that we're saying, you're part of this educational experience. Do you have any advice for our students as they go through their training? What have you seen that doctors have done really well, or what has really bothered you that doctors have done to you over the years and that you'd like these students not to do? I think by pulling the patient into the encounter that way, they feel like they're more part of it. And I think the students really respect the fact that we have enough respect for the patient that we're letting them into the educational encounter. And I think if you do all that, it works out really well. So as you all check out this quote from Dr. Osler, I'm going to have my two students come up here as well as our standardized patient. All right. And if you wouldn't mind just lying down. And so what we're going to do is we're going to do a quick demonstration of what I mean by going to the bedside. Clearly, we're not in the hospital. This is not actually a hospitalized patient. So it can't be exactly the same thing. Also, my poor students who have not been completely ambushed, but at least partially ambushed here, I've told them I'm not going to be asking them any questions. I'm not going to be testing any of their knowledge at the bedside. So you won't actually hear from them. But they've been kind enough to come up here. And this is Dua. Do you mind just waving? And this is Cordelia, two wonderful students who are going to be joining us today. But I'm not going to be asking them any questions. The other two people I'm going to have join me up on stage are Dr. Andrew Elder and Dr. Steve McGee. I fully recognize that I certainly don't have all the answers in this arena. There are many of you out there who probably also have some great ideas about how to conduct yourself well at the bedside. And so what we're going to do is I'm going to do a quick demo here. And then I'm going to turn the mic over to Andy and to Steve. And they're going to give me some feedback. And they're going to probably talk about some of the things that they like to do at the bedside or things that they might do differently or they might do additionally to what I did. And then if we have time, and hopefully we'll have about 5 or 10 minutes, I would love to hear from anyone in the audience who has some additional thoughts. Because again, I know we have a lot of wealth of experience here. So with that, I'm going to put down my clicker. All right. And the way we're going to start out is we're going to pretend that I've already identified the patient for us, okay? And that I've already gone in. So what I always do beforehand is I always walk in and I say, listen, I'm Dr. Kugler. I'm not taking care of you. But on Wednesdays, I take all of our medical students around who are learning internal medicine right now to meet some interesting patients. And I hear that you're a really interesting patient. Would it be okay if the students came in and learned a little bit about why you came into the hospital? And that's kind of the script that I've been using now for the last number of years, and it works pretty well. My hope is it really gets a point across that we're not taking care of them and that this is purely for learning. All right? And I think it usually does. And so we'll pretend that I'm already there and that now we're coming into the bedside. Hi, how are you?
Okay, how are you?
I'm doing all right. I'm just going to adjust your bed a little bit.
Okay.
Let's just... Wow. Slight stage issues, but we're back. What can I call you?
Jocelyn's fine.
Jocelyn. So in case you couldn't hear, our patient is going to be called Jocelyn. And I'm going to have the two of you just kind of walk around to the other side of the bed for right now. Perfect. So Jocelyn, these are our two students. This is Dua and Cordelia.
Hello.
They're both third-year medical students who are learning about internal medicine right now.
Okay.
And so what we'd like to do is we'd love to hear a little bit about how you came into the hospital and like what you were feeling when you came in.
I was feeling short of breath.
Short of breath.
Yeah.
Excellent. And Dua and Cordelia, if you could come over this way just a little bit. So you're perfect right there. And so what we're hearing about is that Jocelyn was feeling a bit short of breath. And so when I think about that, there's clearly many different things that could be going on. We could be worried about the heart. We could be worried about the lungs. We can be worried about the vasculature. And so there's many different parts of the physical exam we should do. What I'd like us to start out with is by looking for the jugular venous pulsation. So to do that, we're going to take a look at the right side. So I want everyone to come on over. Perfect. And so most importantly, I want Cordelia, you and Dua to be up front and center. So I'm going to put down this so that you can get as close as possible. Easier said than done. There we go. Excellent. And Jocelyn, if it's okay with you, I'm actually going to take a pillow out from behind your neck.
Okay.
And so positioning your patient is going to be key. A very wise man once said that the two most important buttons in medicine are going to be the button that turns the exam light on and the button that raises the head of the bed, raises the bed up. So we're going to raise you up just a little bit. All right. And then I'm going to sit you up just a little bit more. So we're supposed to get the patient to about 30 degrees, 30 to 45 degrees here. And ideally, we'd actually take all of your pillows out. For this demonstration, I'm going to leave you with one pillow just for comfort. When you're doing this with patients, I would want you to actually take all pillows away. Okay? Now gather around, stay close here. Jocelyn, if it's okay with you, I'm just going to have you just turn your head just about 30 degrees, perfect, just like that, and then just lie back, and we're just going to be taking a close look at your neck. All right? And so everyone gather around. So make sure that you all can see the neck. Now, the first number of times I started looking for jugular venous pulsations, I often had a lot of problems myself. So clearly not always easy to do. All right? You're looking at the neck. You're looking for things that are pulsatile, right? And so very, very frequently, I would quickly identify the carotid artery as the internal jugular vein. That was not very helpful. And so it took me a while to learn some of the things that you can look for that'll be helpful. And so let me share some of those things with you. Again, this is not easy. We often pretend like it's really easy when it isn't. So some of the things that really, really help me is make sure you have your patient positioned well. Now with our stage lighting here, we're not going to be able to get the greatest view. So I'm going to actually pull out a little light. Now our infection control people don't want me to use the light on my phone in real patient encounters, so I have a different light. But for right now, we're just going to use my light here, okay? And so we can see actually, and hopefully our camera can see, that Jocelyn has a pretty easy EJ that we can see moving there, right? And so you can see her EJ right here, okay? And we'll take a good look to see if we can see her internal jugular vein. It may be a little harder to pick out, but it's right there, okay? And so I do make sure that we have good enough lighting, okay? So lighting is really important. Ideally, in most patient situations, we can just turn on a really bright light above the bed, and you should be able to see just fine, all right? Next thing I do is I really need to make sure that I've identified the internal jugular vein and not the carotid artery. And so some of the things that help me with that is I'm going to take a look and see if it moves. And what do I mean by that? Well, every time we have Jocelyn take a breath, in just about every patient situation, you're going to see that jugular venous pulsation drop. In fact, it often just completely goes away as the negative pressure in the chest draws blood down, okay? And so most of the time, you'll say, oh, there it is. Oh, it went away. Well, that's really helpful. If it stays in the same place throughout the respiratory cycle, you're probably looking at the carotid artery. Other things you can do as well is you can have the patient raise their legs up, okay? And that should push the JVP higher. And the other thing that you can do is push on their abdomen, and that too should raise the JVP higher. None of that should do anything to the carotid artery. Other things that can be helpful is if you're looking at the carotid artery, it's clearly coming out at you, right? Whereas the internal jugular vein is actually, the waves that you're seeing are more depressions than really pulsations. But the thing that has probably helped me the most is really looking at the flickering, right? So the carotid is more of a continuous pulse, right, this. Whereas the internal jugular vein, you should see more of a flickering each time, okay? And so really paying attention to that flickering is probably going to be the most important thing that you can do. All right? And so now we're going to gather around and do one last time to make sure that we can see it. All right? And so I'm going to pull out my phone one more time. And again, I'm not going to put either on the spot. We'll just make sure that we can, once we can see where the internal jugular vein is, now we have to understand, is that normal? And so we do that by finding the point where we see the eye jet, okay? And then we have to find the sternal angle. And so Jocelyn, you're just going to feel me touching your chest if that's okay. Sure. So we'll find her sternal angle. Ideally, we'd expose her a little bit more, but I'm not going to do that right here. But here's her sternal angle. It's right there, okay? And so we would need to get a straight edge, okay, in order to measure this. Now, one of the things I like to do is I happen to know the width of my fingers. And this helps me a lot because I don't always have a ruler with me. Now, it turns out we're pretty lucky that our phones now all have rulers on them, but I actually tend to use this as my straight edge if I need to. And so I can say from right here to here, Jocelyn only is 1 finger's breadth above. And I happen to know that the width of this finger is exactly 1 centimeter, so of my index finger. And so if I can feel that we're only 1 centimeter above, I know straight off the bat that Jocelyn's normal. Okay? Now, clearly, if we're seeing something that looks abnormal, I actually change my routine a little bit. And this may be something that you may not have been taught. And so what I like to do, if I see that something might be abnormal, and this is, again, not the case for you, Jocelyn, is I'm actually going to have the patient sit way up. All right? And so I'm going to put your bed down a little bit and then sit your head up. The reason I do this is because, I know you right now are on medicine wards, and if we think the patient's central venous pressure is really high and her JVP is up, you're probably going to do something to change that, right? And what I really want you to be able to do is come back tomorrow and get her in the same position and see if you've actually been successful in decreasing her JVP. And so what I need you both to do is to come back around. And so since we know that Jocelyn's normal, there's a pretty good chance we have her just about, I won't take you all the way to 90 degrees. Well, I'll take you a little bit closer to 90. You still comfortable?
Fine.
You sure?
Mm-hmm.
All right. I'll take the patient all the way to 90 degrees, and then we'll take a look and see if we can still see her JVP. And I'll be honest with you, her neck veins here look pretty darn flat. I can't even, I could just kind of see down the clavicular fossa. There might be a little pulsation there, but I would say maybe just right there when the end expiration, we can just see it ever so slightly, okay? But what you'll see is with most patients, you shouldn't really be able to see it above the clavicle with them sitting perfectly upright, okay? And that seems to be the case with Jocelyn. But what I would say is, had her JVP been abnormal, what I'd love to see you all do is get a patient up to 90 degrees, measure the number of centimeters above the clavicle, which again, if you know how wide your fingers are, you could do that pretty easily. And then you can put in your chart how many centimeters above the clavicle. And then tomorrow, after you've diuresed her a little bit, you'll be able to see if that's actually come down some. Now, Jocelyn, I'm going to put you back in the position you were in. And again, I just want to stress that all that stuff I was just talking with the students about, none of that was about you because your neck veins look totally normal. Okay? And so there's not at all to scare you. I just wanted to make sure that they knew how to look at neck veins for the next patient they were going to see.
Okay.
Thank you so much. And do you have any advice for our students today as they go around seeing more patients?
You guys are both very calm and comfortable, so keep that up.
Not easy to do under the stage lights.
No.
Thank you so much, Jocelyn. And Cordelia and Dua, thank you so much for being up here. So we've got about 10 minutes left, and I'm going to turn it over to both of you to see if you have any words of wisdom for me.
First, so terrific job, great job. You know, so there's two settings really where you'll be doing your teaching. This is the formal teaching rounds where you don't know the patients, and then the other setting, of course, is you are the responsible physician going on work rounds. So I do pretty much what John does when I don't know the patients and we're just, going around seeing different patients with interesting findings. And I guess the three things, not commenting on the technique at all, but just the three things on how you structured the rounds that I think are so important are, one, are the introductions, saying who you are, who else is here, why we're here. And I usually, my script, it goes something like this. The reason you're here, we're on teaching rounds, and the reason we're here is your doctors mentioned to us that it'd be worthwhile for us to come and spend some time with you. Is that okay with you? And that really what we're doing today is just teaching the students, the residents, the hospitalists, whoever happens to be on the round. So introductions are very, very important. The other thing that you said that I just really make a big deal about is one of the things, we're teaching here neck veins and how to find neck veins. And actually neck veins is a script you can use in every patient. So you go to the bedside, there are no findings. They always have neck veins, so you can always go back to that one. But the thing that you are modeling, John, is the professionalism of the physician and how to communicate with the patient, explaining things, addressing their concerns, avoiding jargon. And if you think about it, that's part of our curriculum as well, teaching how to communicate with patients and professionalism. And just think about in your own practice, the things you use at the bedside. For all of us, the things that we grab onto, how we talk to patients, typically are things that we have seen as learners with some top-notch physician that when they were at the bedside talking to the patient, we go, I want to be exactly like that. That's what I want to do in my practice. I want to talk like that person or be kind like that person or avoid jargon like that person. So actually, that's sort of the hidden curriculum of these bedside teaching rounds. There's the technique, the skill, but also the professionalism and the communication. And then the last point I just want to make that I think is so important is thanking the patient at the end for teaching us and then asking them if they have any questions. Great, thanks.
Yeah, well, thanks very much and good job, John. I would echo everything that's been said about going to the bedside to teach physical exam being more than that, yeah? And it's not just about professionalism. It's not just about a younger doctor seeing an older doctor engage with a person. Yeah, because sometimes they'll see things that don't work. I don't always get it right with a patient, and that's good for them too. So it's about that. But it's not just about the demonstration of a maneuver or a skill. You can get into all sorts of surface anatomy, that might actually be really relevant to them if they're thinking about doing procedures. You can get into applied physiology. I mean, in this example, talking about, what three things happen in the cardiovascular system when you take a deep breath in. Yeah? Your heart rate speeds up, your JVP falls, and your blood pressure falls a little bit. And thinking about those things with them at the bedside is a really good way to get from the books, to real life, I find. So it's not just about teaching the maneuver. One thing with undergraduates and postgraduates that I would do to kind of enlist the help of the patient, I do everything that John has said, but I often say to the patient, my students today, they've got a big exam coming up, and they're going to have to show that they can examine, they can lay hands on a patient and get an idea of what might be wrong. And what I find that does is it engages the support of the patient with the student. It makes them a little more tolerant sometimes of slightly rough or slightly poor technique because they know right away that the person's practicing, but it's leading on to something very important for the learner. And the additional thing I would then do at the end, I guess, is say to the patient with people around the bed, how did they do? And 99 times out of 100, the patient will say, fantastic, even if they weren't very good. But the patient appreciates that this is a big deal. Yeah, they don't get to watch doctors sitting in the library concentrating and trying to take in knowledge, but they see this, and I think sometimes they see how difficult it is. So with the example of the JVP here, the other point I would make, and I appreciate you weren't asking questions today, but I think sometimes if you've got, say, a group of 5 or 6 students around the bed with you, some people think it's a bit of a heart sink if there's a student who, when you say, well, look, you know, because the way I would start with this after revising the surface anatomy for them, I would say, can you see a pulsation in the neck? Now, unless the patient's very obese, you can almost always see a pulsation, right? So that's my route in, because I don't get into measuring it at all. With undergraduates, what I would do would be help them to work out, is it arterial or is it venous? Yeah, usually it'll be an arterial pulse, but it's fine. If they get confident about finding the arterial pulse, that's very important for them. You can lead on afterwards to measuring the JVP. But I'd say sometimes I think people think it's a bit of a heart sink if one of the students says, nope. 5 of them have said, yep, 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 and despite the peer pressure that somebody mentioned at the beginning, the last one says, no, I don't see that. Now that is gold dust. Yeah, so don't feel that this person is going to make the session more difficult. They are very important because what we're teaching is judgment. Yeah, our expertise doesn't really lie in our knowledge anymore, I think. Less and less it's in our knowledge, it's in our judgment. And I think it's very important for learners early on to see that different doctors interpret things differently. It's not a weakness of the physical exam that there's inter-observer variability. There's inter-observer variability with chest x-rays or CT scans. So it's very important, and I welcome the doctor who disagrees, yeah, with a murmur or whatever, because you can say, well, what I want you to do is to get confident in your own technique. Say what you've found. You will never agree with all your colleagues about what's there. And you'll probably see Abram and I on stage tomorrow. It may be that when we examine a patient together with all our combined experience, will disagree about what's there. That is not a problem shouldn't be a problem for the learner, and it's not a problem for the physical exam. So I guess the last thing I would say is the way I take it through with undergraduates anyway, with the pulsation in the neck is, can you see a pulsation? Usually you can. Is it arterial or is it venous? How do I tell them apart? And then I'll tell them how I try and tell them apart as best I can. What the appearance of the wave is, and as John says, the arterial pulse appears monophasic, the jugular venous wave appears multiphasic. So how does it look? Can I feel it? And if I press deeply enough in anybody's neck, I'll feel the carotid pulse, but with light pressure, I shouldn't feel a venous pulse. Can I move it with light pressure on the upper abdomen, hepatojugular reflux? Can I do that? If I can move it, if I can convince myself that I can make the pulse wave move in the neck, it is venous, no doubt at all about it. You can then try the effect of respiration on the wave, but in my experience, particularly in real life, not teaching, particularly when a patient's sick, if you get them to take in a deep breath, it distorts the anatomy of the neck, and I often lose sight of the pulsation. So I don't find that helpful, but I would certainly teach students about it, the effect of respiration. And then finally, the effect of position. Can I move the position of the wave in the neck? And that sometimes might help you sort out the two. So these would be my main points.
Thank you so much, Andy. So it looks like we have 1 minute and 20 seconds for questions. No, so does anyone have any comments? I think I've got 2 up here. I'm going to start right here because I think I saw your hand first. Oh, perfect.
So when teaching physical exam, for example, listening to breath sounds in the lungs, how do you go about talking to the patient about how many students are going to be listening to your lungs, and how do you have them listen at the same time if there's two at a time, or how do you go about doing that when they're actually needing to practice?
Yeah. For me, what I'll usually do is I have them listening, 2 people listening at the same time, and that's purely just logistics. In an ideal world, they each get a chance to be on the right side of the bed and do their full exam, and to be honest with you, just given the time constraints we have, I usually have a student listening from one side of the bed and someone listening from the other, and that's just kind of my style. And then I do try to get everyone to listen. I just ask the patient, I say, are you okay if all the students take a listen to your lungs? Nothing more than that. I'm watching the patient to make sure they're not hyperventilating and that they're okay if there's going to be five students doing that. The thing that I find most challenging goes into a little bit of what Andy just said, is when I ask, all right, what did you guys hear? That they all kind of look at their shoes again. And what I try to emphasize to them is, you know, what you heard is what you heard. That's okay. I tell them my ears aren't necessarily better than yours. In fact, they probably have better ears than me in many cases. And so I really try to let them be able to just tell me what is it that they heard. I might be better at interpreting what I heard, and I'm certainly listening to more lungs than they have. But I really try to give them that free space to respond.
Just a couple of observations first, specifically about the examination. So they get very excited when they see the EJ rather than the IJ. So I always make sure that they understand the difference between the two, because they always interpret EJ as IJ. The other one is the hepatojugular reflex, and that's an art, I have to say, to teach it as well as to understand the physiology of the hepatojugular reflex. And often people just kind of dig the fingers in, take them out, and they say, I did it, I didn't see it. So I think that's something I kind of reflect on as well. The last point is I always make it a point to leave the room exactly as I found it. So you remove the food tray, put it to the side, you take the gown off, and you take the socks off. By the way, I have the most difficulty putting the socks back on. Now I found a way. So, but the patients really don't like it if their lunch, which they got after a 2-hour delay, is now cold and is on the side of the bed. So I think that staging is extremely important.
All fantastic comments. I love the idea of putting that room back together, and I very much agree with your comment on the hepatojugular reflex.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.